Hi, I'm Monica Gonzalez, and I'm pleased to share one of my CGMs case studies in a community setting. We support insulin titration, and we do about 12 sessions to be able to control fasting blood sugars and postprandial blood sugars. This 42-year-old male needs to fix A1Cs before surgery, and surgeon is waiting for that to happen. This patient works in construction, landscaping, BMI 28.8, blood pressure control. He has had uncontrolled A1Cs in the past um, about 6 times, on average of 12. And his medical history is just diabetes type 2 for about 10 years. His current medication is for cholesterol and basal and bolus. His medicine expenses are the minimum because he's using the 340B program discounts available in FQACs. In this other slide, we have that what happened in the last 6 weeks of, of the last 3 sensors. Each sensor lasts 2 weeks, and this patient decreased their average from 234 to 140 milligrams per deciliter. The variability has been decreasing from 35% to 25% from the first and the most recent visit. As you can see, most of the numbers now are following within normal limits. The average per meter is decreasing without hypos and without weight gain. The key interventions for this case is that we have been using CGMs, frequent sessions with diabetes educators, online or in person, in the past 6 weeks. We have been adjusting or tailoring basal and bolus insulins, adding 10% increase every 3 or 5 days based on the standards of diabetes care 2023. And to adjust those bolus doses, we have been using a paper form, shown at the bottom of the slide, that was developed by myself. And that paper tool is similar to what the pump does, but in this case, the patient basically choose what amount of insulin he's going to add based on the meals, and he only needs to choose from the list the food that he will eat, and then he can see how many units are suggested in the table, and that's what he injects. And that system prevents weight gain or hypo episodes. Back in January to June, patient didn't use sensors, but we were still titrating insulin. In January, he started with a 25 units once a day, and gradually we moved him to 25 units twice a day for basal dose. For bolus doses to cover the meals, he started in January with 10 units each meal. By the end of June, he was doing already 20 units 3 times a day. And the first sensor we installed at the end of June was showing in the AGP report, the ambulatory glucose profile, that only 13% of the numbers were in range. That means his time in range was only 30%. And the goal is to reach at least 70% to be able to pass his A1C test. 6 weeks later, while using his third sensor, that means 6 weeks later, his AGP report shows that patient time in range is now 84%. That successful number was the result of the same interventions mentioned at the beginning. Frequent visits, a good teamwork, a good titration, basal and bolus. A patient was involved in the 12 sessions, online and in person, and patient didn't have missed appointments. And the insulin paper guide was the key as well to support insulin bolus titration. Now his last basal dose is 32 units in the AM and 34 units in the PM. And he gradually jumped from 20 units to 26 units 3 times a day to cover the meals. And he only has gained 5 pounds in those past 6 weeks and no hypos reported. As you can see, hypos in the report shows 0%. This is the paper guide to support insulin bolus titration, developed by me, and patient takes this guide home. We use different tables to be able to adjust or titrate about 10% of the bolus dose. Table 3 was given first, and the patient was using about 10 units per meal. Then we gradually adjust or move on to table 4, 5, 6, 7, and now he's using table 8 that gives about 26 units per meal. This is my last slide. In the back of the form, patient has other instructions and how to apply the correction factor. He can use 1 unit per every 50 milligrams per deciliter above 130. And a patient just follow table but doesn't need to do any calculations to correct the blood sugars, and we don't need to explain formula as well. For example, if the patient has 300, if the patient has 300 before the meal, he only needs to inject 3 extra units plus the units that he has to use to cover the meal. In conclusion, on this case study, we know this patient will pass his A1c. We can predict because if he continued the same patterns of a time and range above 70, he will have an A1c around 7%. To avoid medication interruption and pharmacy supply, we need to order the medication correctly with the correct amount. For example, for table 8, for the bolus dose, we need to order 80 mLs with 0 refills to cover 3 months supply. And we can write the daily dose of 26 units 3 times a day. That comes from divided 80 divided 3. His insulin carb ratios are 1:9. That equals 8 units of insulin per 15 grams of carbs. This case was successful as well because he was walking daily 30 minutes before or after meals. I hope you enjoyed this short case study, and we will continue to share more. Stay tuned. And I'm Monica Gonzalez, diabetes educator and dietitian from Illinois.